Okay. Today I will make a brief introduction to olfaction, taste and swallowing. Each small function is very nicely organized in the neuroaxis. So I will club because olfaction, taste, swallowing all are one function. You smell a thing, then you taste a thing and you swallow a thing. So they are linked functions. So here Krishna is serving butter to his friends. You can see that. So we'll go. So this is, I will first talk about olfaction, taste and swallowing. These topics are less often taught in the colleges. So we fail to understand the beauty of the nervous system and think only stroke or something like that and deviate from the beauty of the nervous system. So what is common between taste, smell and swallowing? You see, taste and smell leads to swallowing. So they are linked. And both these respond to chemical stimuli. We have seen sensory pathways, motor pathways. They respond to sensory stimulation, light, temperature, heat, like that. Whereas olfaction and taste respond to chemical stimuli. The chemical substances which produce smell or taste is sensed. Then end organ in these two systems are chemoreceptors. They are not pain receptors, they are not touch receptors, they are chemical receptors, they are chemoreceptors. And these two functions are interdependent. Taste and smell is interdependent. And smell and taste are misinterpreted as flavor involves both. You see, taste is salt, sugar, bitter, sour, like that. Smell is different smells are there. But flavor is a combination of taste and smell. For example, coffee. Coffee has a taste and it has got a smell, and both together leads to the enjoyment that coffee gives. So smell and taste are misinterpreted as flavor involves both. A person who has taste but does not have smell will tell us he has no taste. Then when we independently ask, is he appreciating salt, is he appreciating sweet, he will be. Then why did he say taste is not there? Because they refer to the combined effect, that is the flavor. And chemical communications take place via pheromones. No? So pheromones are, the word pheromone means carry exciting information. So this communication takes place through pheromones and senses noxious odors, the wrong odors. You know that odor of carbon monoxide, of course it doesn't have, and odor of cyanide. So all these are noxious odors, and so you avoid poison. So not only you enjoy taste, but you avoid poisonous substances also by using these chemoreceptors. So smells, we have got about 7 to 10 subtypes of smells, but they combine in several permutations and result in unlimited combinations. Basic smells are about 7 to 10, but unlimited combination of various smells leads to several types of smells. Then there are 5 basic tastes that stimulate and are perceived by our taste buds. That is sweet, salt, sour, bitter, and umami or savory. So these are the 5 basic tastes. 7 to 10 smells and 5 basic tastes are there. And flavor is combination of olfactory, gustatory, and trigeminal. Olfactory is smell. Gustatory is the primary 5 tastes, and trigeminal is the somatic sensation, that is touch, pain, temperature. So all these together give rise to the flavor. The number of smell is unlimited. Even though the basic smells are 7 to 10, the combinations are unlimited, and hence flavor. You see, smell itself is unlimited, taste is 5, and they combine in several combinations, result in flavor. And flavor is therefore again unlimited, more than 10,000, in spite of only 5 basic tastes and 10 basic smells. So olfactory neurons are the only ones exposed to the environment. So these are the nasal epithelium. In the motor neuron disease session, I have told about unipolar neurons, bipolar neurons, unipolar neurons, and multipolar neurons. So these olfactory neurons are bipolar neurons. And they are about 6 million in number, and they are located in the superior posterior part of the nasal cavity. And the fibers that they give rise to, these bipolar neurons give rise to the fiber, and that fiber is the olfactory nerve. And these olfactory nerves travel through the cribriform plate. And this is the olfactory epithelium. Here you have the bipolar neurons. And through the cribriform plate, these several nerve fibers perforate and enter the orbital part of the frontal bone, where you have got the olfactory bulb. So, so this is the nasal cavity with the various turbinates, and you have got the olfactory epithelium, and this is the cribriform plate through which these nerves perforate and reach the olfactory bulb. This is the sagittal cut showing the olfactory bulb. So here in the basal part of the brain, this olfactory bulb is situated in the orbital part of the frontal bone. And then it goes posteriorly and divides into medial and lateral stria and goes to various structures involved in the higher processing of olfaction. So here you can see that the olfactory bulb is there, and it divides into a lateral and medial stria. So, and it goes into the primary olfactory cortex complex. That is the anterior olfactory nucleus in the pyriform cortex, the anterior cortical nucleus of amygdala, periamygdaloid complex, and rostral entorhinal cortex. And then go have a neothalamic relay. So primary olfactory area, olfactory bulb, olfactory tract, it goes in medial stria, lateral stria, and they enter into the primary olfactory cortex. And then you have got the secondary olfactory cortex, that is occurs via the dorsomedial thalamus, amygdala, uncus, and orbitofrontal cortex. So primary relay, and there is a association relay like vision. We have had a session on vision. I have told us the primary visual area and the secondary visual areas, like that primary olfactory area and secondary olfactory areas which modify the olfactory input. So we have the bipolar neurons, which is there in the posterior superior part of the nasal cavity, nearly 6 million. They form the olfactory nerve, and the axons of the mitral cells and granule cells and tufted cells form the olfactory tract. And the medial stria goes via the anterior commissure, septal nucleus, hypothalamus, and the limbic system. The lateral stria goes to the anterior perforated substance, medial and lateral amygdaloid nucleus, pre-pyriform region, and forms the primary olfactory cortex for learning of various smells and aversion, which is favorable, which is to be avoided. So that is the lateral stria. This is more developed in the animals than in the human beings. So this is one system more developed in the animals. That is why we use sniffer dogs to identify bombs and investigation of murders and all. Because this pyriform cortex, the anterior perforated substance, and the pre-pyriform regions are more developed in the lower animals than in the humans. And secondary olfactory cortex is located in the uncus of the temporal lobe, anterior part of the parahippocampal gyrus, and the orbitofrontal cortex. Medial and dorsal nucleus of thalamus, amygdala, hypothalamus, septal area for vegetative functions. Smell is having vegetative functions like eating and having eating, mating, and avoiding the opposite animals by making boundaries. So those things are through the medial and dorsal nucleus of thalamus, amygdala, hypothalamus, septal area, associated information processing of the various smell. When a lion is there and this is an opposite gang, then the lion in the home will identify that the villain lion has come by the smell sensed through these structures. Then from uncus via the medial, that is the secondary olfactory, median forebrain bundle, fibers go to the orbitofrontal cortex and through the reticular formation to the dorsal nucleus of the vagus and salivatory nucleus, the medulla oblongata, for the classical conditioned responses. So this information, as I said, it can be aversion or it can be favoring various vegetative functions from eating, mating to avoiding dangers. And for eating you and other things like that, you have got conditioned reflex. We have seen this conditioning, Pavlovian conditioning, why this increased salivation takes place when you have a conditioned stimulus with the food. So that is by the median forebrain bundle, which carries the information from the uncus to the orbitofrontal cortex, and that tells you that food is coming. And then through the alerting system of the reticular formation, the autonomic nerves are stimulated so that saliva, which is needed for digestion, is secreted. So this is the secondary pathway is for conditioned reflex. Primary pathway is for vegetative function, sensing favorable smell, identifying the mate, avoiding danger, and avoiding dangerous smells. Whereas secondary pathways of the olfaction is for the conditioned reflex associated with the appreciation of smell and taste. So once you appreciate smell and taste and you start eating, you need a digestion for which various secretions are needed, and that is mediated through the secondary pathway through the median forebrain bundle. So you have got the olfactory receptors, then we have got the olfactory bulb, and then we have got the piriform cortex, then the lateral hypothalamus, the thalamus, and median forebrain bundle to the orbitofrontal cortex, from where through the reticular formation inputs descend to the brainstem and activate salivation, which is needed for conditioned reflex. So that is the pathway. This is the orbitofrontal median forebrain bundle, and from there through the descending pathways, reticular formation to the cranial nerve nucleus for increasing salivation. So then we have got a taste area. No? In the insular region, we have got the taste area, that is to appreciate taste, and just nearby is the olfactory cortex. This is the uncus, secondary olfactory cortex. This is the medial orbitofrontal cortex where the olfactory bulb and tract is going, and inside this region is the taste. So taste and smell are linked here through the primary olfactory pathway through the orbital part of the frontal bone, which contains the olfactory bulb and the tract, the lateral and the medial stria, through the piriform, and the secondary olfactory cortex, there is uncus, and inside the sylvian fissure you have got the insula, which is the taste area. So this converging of the olfaction and taste function is taking place in the central nervous system also. So primary olfactory cortex has got an anterior olfactory nucleus anteriorly and posterior olfactory cortex posteriorly. And the posterior olfactory cortex is formed by piriform cortex, periamygdaloid region, and lateral entorhinal cortex. And what are all the connections of the posterior olfactory cortex? Intrinsic local, that is between the anterior olfactory cortex and the posterior olfactory cortex inside. So there is an intrinsic connection, and there is a association connection to the anterior olfactory nucleus and extrinsic to the olfactory bulb. So there is a connection within and then with to the anterior olfactory nucleus and extrinsic to the olfactory bulb and non-olfactory areas. Why non-olfactory area? You sense a dangerous smell. Then you have to activate the motor areas, the sensory areas. Open your eyes. See, a lion is waiting to swallow you. The smell that you got is the smell of the lion, no? So you have to activate the non-olfactory areas for action. So that connections to the posterior occipital cortex, olfactory cortex, is connected to the non-olfactory areas for action mediated through the olfactory information process, and modulatory input from locus coeruleus, raphe nucleus, diagonal band of Broca, and ventral tegmentum. These are mainly the locus coeruleus is noradrenergic pathway, raphe nucleus, diagonal band of Broca, they are concerned with the memory. So learned olfactory information processing. And neocortical projections to the insula, orbital cortex, and subcortex connection to the hypothalamus and thalamus, where there is interaction between taste and smell, which I showed in the previous picture. Then you have got what is this endorenal area of the secondary olfactory cortex. This is a area of the parahippocampal gyrus. This is a part of the parahippocampal gyrus and receives numerous connections from the primary olfactory cortex. We saw the primary olfactory cortex, which is having an anterior and posterior division. The posterior division connects to various non-olfactory and olfactory areas. And now we have got the secondary olfactory cortex, that's the endorenal area of the parahippocampal gyrus, which receives numerous connections from the primary olfactory cortex, which we just went through. And this forms the limbic connection for emotional and autonomic response to olfactory stimuli. Like I said, it is for eating, mating, avoiding danger. No? So the emotional response, if you see a person of the opposite gender in animals or all living things, the reactions are different. And if you see a dangerous animal which is coming to fight, then again the reactions are different. So this forms the limbic connection for emotions and autonomic responses, which I just now showed, that through the median forebrain bundle, the information goes to the medial orbitofrontal cortex. From there, through the reticular formation, descends to the brainstem nuclei and results in salivary secretion. So that is the second form of connection. The hippocampi and amygdaloid nuclei on the two sides are intimately related through the anterior commissure. So anterior commissure connects these two structures. And orbitofrontal cortex, the dorsomedial and the submedial thalamic nuclei, the lateral hypothalamus, the amygdala, and the hippocampus have reciprocal connection for regulation. So all this, orbitofrontal cortex is the higher cortical discrimination, and thalamic nucleus is for sensory recognition, hypothalamus is for memory, amygdala for the emotional component, and hippocampus is for the memory component. So they are all linked in a circuit, so that olfactory function serves very serious functions. So the pyriform cortex is odor quality, so that recognizes the odor quality, identity, familiarity. So this odor belongs to lion, this odor belongs to goat, this odor belongs to chick, that kind of identity, familiarity, and remembering of odors, and coordinating between olfaction and taste. That is the function of the pyriform cortex. Amygdala, emotionally significant as pleasant or unpleasant odor. And endorenal cortex pre-processes information entering the hippocampus and involved in learning and memory. So this smell is dangerous, this smell is safe, this smell is friend, this is rose, this is lotus, that kind of thing. And the caudal orbitofrontal cortex has odor detection, and the more rostral regions are involved in working memory. The medial orbitofrontal cortex and ventromedial prefrontal cortex are activated by pleasant odors, and the lateral orbitofrontal cortex and neighboring inferior prefrontal cortex are activated by unpleasant odors. So we saw the median forebrain bundle connecting the olfactory areas to the frontal cortex, where the medial orbitofrontal cortex senses the pleasant odors and the lateral orbitofrontal cortex senses the unpleasant odors. So what are the unique features of olfaction? Olfaction is the oldest sensory modality which identifies the mate, the territory, and environmental dangers. And dogs have 300 to 10,000 times more sensitive to smell than humans. And humans have 10 to 40 million receptor neurons, whereas dogs have 1 billion neurons. And the only cranial nerve which is in direct contact with the external environment through the nasal epithelium in the posterior part of the nasal cavity. And the surface epithelium has IgA, IgM, lactoferrin, lysozyme, and odorant binding proteins to prevent the organisms entering into the brain. So they are immune complexes. They prevent the organisms from entering into the brain from the nasal cavity. And this is the only nerve directly exposed to the exterior. So and there is role of entry of wrong toxins, environmental materials, which will produce epigenetic projection of predisposed patients with Alzheimer's disease, and continuously replaced by newly formed cells every 60 days. And olfactory receptor neurons sit on the stem cells. Very interesting that it is continuously replaced every 60 days, and these receptor neurons sit on stem cells, multipotent stem cells, and multiple nerves, nearly 20 in number. So most other nerves are pairs, whereas olfactory is multiple nerves, 20 in number. And thalamic relay is not there till primary olfactory cortex is reached. So till primary olfactory cortex is reached, unlike other sensations, there is no thalamic relay. The receptors of olfaction are called telereceptors. They are called telereceptors as they gather information available far off. So these receptors are chemoreceptors, I have told. And these chemoreceptors need not come into contact directly with the smell. The smell happening some kilometers away can be perceived. Therefore, they are called telereceptors. And olfactory fingerprint. Each human has got a unique shades of smell. They identify with clarity that might not be identified by another. So each one of us have got specific skills, so which we identify and recognize the persons, the animals, and other objects around us. So what is this tip of the nose? So these are the various unique features. And what is the tip of the nose phenomena? The inability to name an odor, even though it is very familiar, no lexical access, as mostly it is on the right hemisphere and have no thalamic relay before reaching the cortex. Hence, there is a lesser retrieval. So tip of the nose phenomena is you feel that that particular smell I know, but you are unable to recognize. That is called tip of the nose phenomenon. And we cannot smell while we are asleep, as attention is not there. So smell needs attention. So when that is another unique function of olfaction. When you are sleeping, we generally do not identify general smells. And memory of the smell is in the amygdala and hippocampus, and emotions are in the limbic system. So there is a link between emotion and emotional memory for limbic olfactory information. And what is this cognitive habituation? So prolonged recycling time. So there is a habituation of familiar environmental smell, so that you don't perceive them anymore. For example, people living in a particular surrounding, after a particular period of time, they stop sensing those smells. And odor memory can last 1 year, while visual memory lasts only few months. And women generally have a better oral memory, lower threshold than men. And irritant smells and sneezing is through the trigeminal nerve, not through the olfactory nerve. Irritant smell and sneezing is through the trigeminal nerve, not through olfactory nerve. Very important to remember. And we generally do not dream smell. In dreams, we see, we hear, but smell, if you think, we ourselves will know that generally we don't get a smell in our dream. So these are unique features of olfaction. Then we have got a parallel olfactory system that is called omeronasal organ. It is for non-volatile matter processing. We thought that the olfaction is telereceptor. Volatile substances get dissolved in the air and travel long distance and you smell it. There is non-volatile matter processing, like processing of pheromones, that is having role in the reproductive behavior and endocrine system. And olfaction and COVID, there is a sudden no obstructive signs, cleft of nose affected, and may recover suddenly. So there is two types of olfactory loss in COVID infection. One, it is sudden and there is no nasal obstruction, and that is due to involvement of the sustentacular cells which get damaged due to angiotensin converting enzyme to receptors. That results in sudden loss of smell, but it recovers. And as it is the support cell and not neurons that is affected, it can suddenly recover. So that is the quick involvement of the sustentacular cells, but some don't recover because of the splash damage. That's the second stage when neurons are damaged. So in COVID, there can be just damage to sustentacular cells where the smell will return. And if the damage happens to the olfactory neurons, that does not recover. Both happens in COVID infection. So it is we have got a very old olfactory system, more primitive responses to olfaction, salivation, licking of the lips, primitive emotional drives to smell. And less old olfactory system is learned control of food intake. So new evolved olfactory system, we should not just eat because something is very tasty. So you got learned control of food intake, aversion to food that have caused nausea and vomiting, and motivation and emotion linked to that eyes. Even if somebody is giving you a food, that person is shouting at you, abusing you and giving food, you won't eat. So that is all becoming with a less older system. Whereas primary old system is indiscriminate olfactory function-based actions. Second is little more discriminate action on olfactory information. And the newer system is conscious perception and analysis of odor. The hippocampus for memory and odor discrimination. We know that this odor came from my father's shirt, which he wore for so many years. So that links the memory-based olfaction. And here we have shown the limbic system, which has shrunk into a very small system in the humans, whereas in the lower animals, limbic system is very big. So this is one system which has shrunk in evolution in humans. Then olfaction, memory and immersion. Orbitofrontal cortex, olfaction is processed here. We saw that through the median forebrain bundle, the information goes to the orbitofrontal cortex, where the medial and lateral part is there. You have got unpleasant odor and pleasant odor processing in the medial and lateral part respectively. And olfaction is processed here in addition by assigning affective value, emotional judgment, which is important for reproductive and maternal behavior. So olfaction, which emotional linking and affective value processing through the frontal cortex connection results in the type of reproductive and maternal behavior. And there is something called aromatherapy. Improves and putting a favorable or emotionally positive aroma in the environment improves and alters the mood, and therefore improves the performance and well-being of people working in a particular environment. And olfaction is inherently a higher cortical sensory function, and olfactory network operations might give new insight into higher cortical functions. So this is a condition seen in young females. Normally we know that during pregnancy people are increasingly sensitive to smell. Supposing a pregnant woman says that my sense of smell has reduced, you should be very careful. It may be the beginning of a very malignant tumor, which is hormone dependent, it grows, and common in young people, and that is esthesioneuroblastoma. So it's a very, very, very malignant tumor. So it will start with no signs of tumor, but loss of smell in a pregnant woman, and then it grows in the frontal lobe, very poorly responsive to treatment and very highly malignant. So this is the smell memory of Sri Ranganatha. That is the story. We know that in Sri Rangam, when the Mughals were invading, there is something called Sri Ranganatha's travel. So people carried the original Sri Ranganatha through several places for several months to hide him from the invaders. And they kept a duplicate Ranganatha there. Then after the invaders went off. Several decades later, both Ranganathas were brought back, and nobody knew who is the original Ranganatha and who is the second Ranganatha made, because the people of that time had died. And so what to do? People were confused, and there was a dhobi who was washing the clothes of original Ranganatha, and now he is more than 90 years and he is blind, but his smell was good. So he will tell, this is a true story, he will tell, put a cloth over both Ranganathas overnight, fold them and bring them to me and mark on whom it was put, then I will tell you the original Ranganatha. Because he as a child was washing the clothes of the original Ranganatha, and he identified the smell and identified the correct Ranganatha. And so now, and he said, this is Nam Perumal. Nam means in Tamil, our. So this cloth belongs to our Ranganatha. So Sri Rangam Ranganatha is also called Nam Perumal, because that is how the person who washed his clothes called him and identified the original Ranganatha by the smell memory when he has become 90 years old and blind. Then what happens in olfactory disease? It can be central alteration or peripheral depending on the respective origin, loss or decrease. It can be either decreased or loss of smell. We saw the COVID, what happens, I told. So, or central, there is altered smell. In central disease, there is alteration of the smell, whereas peripheral, there is only loss or decrease appreciable smell. So you got scratch and sniff odor pads. For testing this, you got scratch and sniff odor pads, olfactometry, and olfactory evoked responses, and University of Pennsylvania smell identification test. So these are the various tests available. So in the peripheral end organ, there is only loss or decrease. Whereas in central, there is altered smells. So what are these terms? Anosmia, absence of smell sensation is called anosmia. Usually that is peripheral. Partial anosmia, that is also peripheral. The smell is slightly reduced, but it is still perceived. Hyposmia is decreased sensitivity to odorants. And hyperosmia is abnormally acute smell function. Happens in pregnancy or of migraine. So those situations you do not tolerate normal smells and you feel it produces headache. And dysosmia is distorted smell perception. That is a higher olfactory connection function where one smell becomes distorted into another smell. Phantosmia or olfactory hallucination. That is perception of an odor when none is there. It can be an olfactory epilepsy. So, or of an epilepsy coming from the secondary olfactory cortex, that is uncus, will present as a sudden smell which comes and goes. That is olfactory hallucination or phantosmia. And olfactory agnosia, inability to recognize an odor and inability to classify, contrast or identify odor sensation verbally, though the ability to distinguish between odors is present. So that is again a higher function. So lower level, loss of smell, partial or complete. Whereas increased smell is also peripheral. That happens in conditions like pregnancy, migraine. And altered smell and episodic smell and smell agnosia or higher cortical connection induce problems. So we have got a sensory receptor, the primary neuron, where you get hypoxemia, anosmia, dysosmia, and it can be unilateral. Whereas other neurological findings associated with the sensory receptors, head injury might have happened. There can be CSF rhinorrhea, respiratory infection, exposure to toxins. That is the peripheral smell-based problem. And secondary neurons, hyposmia or anosmia. And these are that happens in a condition called Foster-Kennedy syndrome, where you have got olfactory groove meningiomas. And then you have got olfactory bulb cells, dysosmia, disinhibition and change in the personality, usually seen when there is an altered smell due to the orbital part of the frontal lobe getting involved. And this is seen commonly with neurodegenerative disorders. And anterior olfactory nucleus, the disease can be unilateral. As we have seen previously, there is a medial stria, lateral stria. Medial stria goes to the anterior perforator substance. Medial stria goes to the opposite side, and lateral stria goes to the anterior perforator substance. And this will produce associated frontal lobe features like gait apraxia, disinhibition, personality change, and this is seen in frontal lobe tumors and pituitary tumors. And medial dorsal nucleus of thalamus produce decreased odor identification and decreased or altered threshold of appreciation, and seen in conditions like Wernicke's encephalopathy and with all other accompanying features. And then you have got a primary and secondary olfactory cortex disease where there is decreased identification or increased odor threshold, and there can be associated features like lip smacking, automatisms, or of seizure, dementia because it is a frontotemporal involvement, and memory loss, and subcortical involvement like bradykinesia, extrapyramidal features, and there can be due to the visual pathway involvement, hemianopia, and we have got common causes or degenerative diseases of the nervous system and epilepsy. Then we have got psychogenic loss of smell where organic loss of smell. So psychogenic loss of smell, flavor is normal. So patient will say, after I was hit by my opponent, I lost my smell. Okay, what about flavor? They will say flavor is present. It is not possible because smell and taste we saw is a combined function, and they cannot be lost separately. So if the smell is lost, flavor is lost normally. So a psychogenic patient, he says, I lost my smell, but flavor is present. And irritant substances are also lost in psychogenic. And I have told that irritant substances are carried by the trigeminal nerve. And patient can try suppressing, whereas try suppressing sneezing, thinking that the smell organ is carrying the sneezing, whereas sneezing is carried by the trigeminal nerve. Whereas organic flavors are affected and irritant substances will be identified. So you give ammonia, they will identify and they will have normal sneezing. So sneezing and irritant substance identification is through the fifth nerve. Whereas a psychogenic patient will say he is having difficulty in sneezing and he cannot identify irritant substance also, and flavors are normal. So like that we differentiate psychogenic versus organic. The central causes, we have got olfactory aura, that is, as I told, episodic smell, aura of seizure, migraine, pregnancy, phantosmia, phantom odor experience, unknown odor experience, and psychiatric etiologies for olfactory distraction can exist with schizophrenia, depression, alcoholic psychosis, and olfactory reference syndrome. So there are overlaps of many terms used on dysosmia, distortion of the sense of smell. One smell becomes distorted into something else. Troposmia or parasmia, perceived distortion. So distortion of the sense of smell and perceived distortion, they are called by two different terms, but they are actually same terms. So these are some overlaps. So troposmia or parasmia is actually the same as dysosmia, but different terms are used there, resulting in overlaps. And phantosmia is abnormal smell lasting longer than few seconds. And olfactory hallucination usually is unpleasant and it lasts for few seconds. Cocosmia is perception of bad smell with or without a stimulus. And eucosmia is a pleasant smell perception. Then what happens to smell and disease of like dementia and other disease central nervous system? Decreased ability to smell is among the first sign of Alzheimer's disease, and some patients with Huntington's disease, frontotemporal dementia, and multi-infarct dementia. And we have got conditions like hypothalamic syndromes of Kallmann, DMAS syndrome, and congenital septo-optic dysplasias, and dementia pugilistica secondary to punch drunk, neurosyphilis, and esthesioneuroblastoma. So these are conditions where you have a relationship between dementia and smell. This is a hypothalamic hamartoma child. This is called Poolister-Hall syndrome. So they will have this high arch palate, slit in the lips, decreased appreciation of smell, and hypothalamic hamartomas. This is a hypothalamic hamartoma. Next, we will come to taste. So we have finished grossly the outline of smell. Now we are coming to taste. So taste receptors, I have already told that there are 5 basic taste, and the taste receptors are the taste buds. So taste buds are chemoreceptors. We have already seen their chemical stimuli, chemoreceptors, and 50 to secondary micrometers, they send substances dissolved in fluid. So they, unlike the olfactory, which is in the air, and telereceptors, whereas taste receptors perceive things which are dissolved in fluid. And the locations, we have got the dorsum of the tongue, on the epiglottis, soft palate, and pharynx. Taste receptors are located in all these areas. And you have got fungiform receptor, filiform receptor, circumvallate receptor, and foliate receptor. Fungiform receptor is rounded, numerous, and have 5 taste buds at the top. Filiform receptor is small, conical, no taste buds, and arranged in right to left of the midline and confined to the back and edge of the tongue. And circumvallate is prominent, arranged in a V form at the back of the tongue. And each one has, they are about 10 to 12 in number, and each one of them have 100 buds. And foliate is found occasionally on the posterior lateral surface of the tongue. So we can see that these are the fungiform papillae. These are the circumvallate papillae. This is the lingual tonsil and palatal tonsil, epiglottis. And this is a taste bud. And we have got the taste fibers. So we have seen the taste receptors, which are not telereceptors. They are receptors which respond to chemical substances dissolved in the fluid. Then how do they travel? From the anterior 2/3 of the tongue, you travel through the chorda tympani nerve, and through the which hitchhikes the facial nerve. And posterior part is glossopharyngeal nerve, and epiglottis is vagus nerve. So all these 3 nerves, that is the chorda tympani nerve, which enters in the facial nerve, glossopharyngeal nerve, and the vagus nerve, they enter into the nucleus solitarius of the medulla oblongata. From there, they join together at the medulla. All the 3 nerves carrying taste information enter into the nucleus solitarius, join together, and enter to the pons, cross to the opposite side, thalamic nucleus, and then goes to the gustatory cortex, which I showed in the introduction only, that in the uncus is below, medial orbitofrontal cortex is anterior, and in the insular region, you have got the gustatory cortex. No. So that is the olfactory pathway. All the 3 nerves go to the solitary nucleus, enter the pons, cross the opposite side, enter the thalamic nucleus, and enter the gustatory cortex in the insular region. So this is again, we have from the nucleus of the tractus solitarius, axons of the second order neuron ascend ipsilaterally, what I showed only, and then in the medial lemniscus, and pass directly to the ventral posterior medial nucleus of the thalamus. From the thalamus, the third order neurons pass the thalamic radiation to face area of the somatosensory cortex in the post-central gyrus. So it goes to the insular region and also to the post-central cortex, that is the sensory cortex for real somatic sensation, and also pass to the anterior part of the insula, which is anterior to the face area, probably mediates conscious perception of taste and taste discrimination. So that is the higher taste pathway connection. Fibers of the 7th nerve are more responsive to sweet and salt, and discrimination of taste quality. Fibers of the ninth to sour and bitter through all regions, though all regions can perceive this. And they project to the nucleus of the tractus solitarius that we saw just now. And then enter into the pons. And third order neurons project to the thalamus and then to the sensory cortex and the insular region. So taste is the oral component of the visceral afferent system. So we have got a visceral afferent mediated behavior. So taste is the oral, just like we saw the olfaction related behavior, taste related behavior is also there. So taste is the oral component of a visceral afferent system. And this includes gustation, respiration, cardiovascular, and gastrointestinal function. Output from the nucleus of tractus solitarius reaches the forebrain, which provides input to the motor system for pattern generation. So the taste has been felt and the information is conveyed to the forebrain. And that forebrain will decide whether you have to swallow this or no, refuse that. So once you have decided you have to swallow, then the information is sent to the motor system that generates the pattern for feeding. So this is your favorite food. So you can start eating. Like that, the forebrain tells the motor cortex. So the motor cortex will prepare the motor schema for the mouth, the tongue, and for the salivation, and then for insulin release for digestion and activating the swallowing mechanisms. And for aversive taste, protective behavior like gapping, chin rubbing, forelimb flailing, and fluid rejection. So if you have an aversive taste, another set of motor activity which rejects the swallowing mechanisms will be produced. And afferents from the 9th, reflexive oromotor behavior. And 10th is superior laryngeal nerve, that is for protecting the airway during swallowing. So 10th nerve has got a superior laryngeal branch that, apart from carrying the sensory information from the epiglottic region, the superior laryngeal nerve protects the airway during swallowing by causing constriction of the airway. So that is the taste pathway from below to the cortex to the taste pathway mediated behavioral rejection and activation of motor or rejection of motor schema for swallowing or vomiting. Then what are all the terms? The ageusia, absence of the sense of taste, is ageusia. Hypogeusia is diminished sense of taste. Dysgeusia is disturbed sense of taste. And drugs like captopril, penicillamine, there is temporary loss of taste. So now we have seen taste and smell. Once the taste and smell is favorable, we have to swallow. So when awake, swallowing is a planned maneuver at a chosen plane with or without a suitably prepared bolus. Voluntary swallowing process is initiated voluntarily, not necessarily occurring as a response to stimulation by a bolus. So we have got a planned swallowing maneuver and you have got a reflex swallowing maneuver. So bolus preparation is a separate process and may involve chewing. So you have to prepare a bolus. Once the food has been appreciated and the brain is telling, okay, you can swallow this, then it involves a number of processes. First is the voluntary swallowing, and then there is a reflex swallowing without the bolus. So voluntary swallowing involves the bolus. So you have to prepare the bolus. So bolus preparation is a separate process and it involves chewing. So first you put your food into the mouth and you have to chew it. That is carried out by the 5th nerve. And then when the food is chewed, the mouth should be closed. Mouth, if it is open, the chewed food will leak out through the mouth. So mouth is closed by the 7th nerve. And this food which is chewed and put into the mouth should be pushed to the posterior part of the pharynx so that it is swallowed. So for that, you have got the lingual muscles, tongue muscles. So 12th nerve. So 5th nerve chews, 7th nerve keeps the mouth closed when the chewed food is kept in the floor of the mouth, and the 12th nerve or the tongue pushes the bolus to the pharynx, posterior part of the mouth. and initial propulsion of the bolus is taking place by the 7th and the 12th nerve. So you chew the food, make it into a crushed material and keep the mouth closed with the 7th nerve. And after that, the prepared bolus is pushed posteriorly by the tongue. That is the 12th nerve. And that is the first phase of swallowing, the voluntary swallowing, that is called oral phase. And then the second phase, that is the pharyngeal phase. The reflex starts from the second phase, on the pharyngeal phase. So you got a oral phase, you got a pharyngeal phase, and you got a esophageal phase. So 3 phases. You got oral phase, you got a pharyngeal phase, and an esophageal phase. So oral phase, we have seen 5th, 7th, and 12th nerve. Pharyngeal phase, you have got the 5th, 9th, and 10th nerve. And difference the peripheral swallowing center of the brainstem. So they send, so the food bolus is now reaching the pharynx, and the efferents from the pharynx are sent to the peripheral swallowing center of the brainstem, and that makes the schema. So all this food is pushed to the pharynx. So pharynx is telling, I have received something. What do I do with this? So this information is carried by the branches of the 5th nerve, the 9th nerve, and the 10th nerve to the brainstem. In the brainstem, there is a secondary motor schema preparing area that I will be telling. And from that, the food is pushed into the esophagus with the help of the brainstem area. So this is the oral phase, and we can see the nerves. You see the trigeminal nerve, you see the 7th nerve, and from the posterior part, you have got the lower cranial nerves. So they go to the brainstem, and in the brainstem, the lower cranial nerve nucleus is there, respiratory center is there, nucleus of the tractus solitarius is there. So that is the brainstem schema generator formed by the cranial nerve nuclei, lower cranial nerve nucleus, nucleus of the tractus solitarius, and the respiratory center. The respiration should be suppressed during swallowing. So these three act, nucleus tractus solitarius, lower cranial nerves, and the respiratory tract centers act together and suppress the respiration and facilitate swallowing. So that is, after this, by the Sherrington scale, that's the brainstem. So first we saw the oral phase, then the food is reaching the esophagus, then the pharyngeal, at the pharyngeal phase, the brainstem integrator is activated, which consists of the cranial nerve nucleus, respiratory center, and the nucleus of the tractus solitarius, where the respiratory center is suppressed and the motor schema is facilitated, and that opens the upper esophagus and moves the bolus into the esophagus and closes the airway. That is the function of the brainstem integrator. It closes the airway and pushes the food into the esophagus. So, afferent fibers from the anterior two-thirds of the tongue travel in the lingual nerve to the cauda tympani nerve and then to the gustatory nucleus. Taste fibers from the posterior third of the tongue, the palate, and the palatal arch travel via the glossopharyngeal nerve and the ganglia nodosum and end in the gustatory nucleus. And there are 2 ascending pathways from the gustatory nucleus, one to the hypothalamus, the other to the thalamus, and then to the gustatory center in the cortex, the area 43 in the parietal operculum. And food reaching the palate through the cranial nerve 5, 9, 10 and their nuclei, and the medullary network, which I said in the brainstem, the tractus solitarius, respiratory center, and the vomiting center. You see, when the food is kept in the mouth and it reaches the pharynx, it may be a good food or the bad food. So at that level, if it is a good food, the respiratory passages are suppressed and voluntary movements are facilitated. But if the food is a bad food, the vomiting center is facilitated. So instead of pushing the food into the esophagus, you vomit it out. The vomiting center is also there in the brainstem only. We know the area postrema and the chemoreceptor trigger zone. So vomiting center is the area postrema and the chemoreceptor trigger zone that coordinates swallowing and breathing. And insula at locus coeruleus and salivatory nucleus forms the autonomic component of swallowing by increasing the secretions. And soft palate is moved up by the levator valley palatini and close the posterior wall of the pharynx and seals the nasopharynx. That is carried out by the intermediary neural integrator in the brainstem, which I said is formulated by the cranial nerves, tractus solitarius, respiratory center, and the vomiting center. And difference direct bolus oropharynx, pharyngeal constricts or constrict, larynx elevates, and nasal speech is due to escape of air, and nasal regurgitation is due to escape of fluid or solid when there is no proper closure of the airway. When the brainstem integrator is defective, plus proper suppression of the respiratory passages is not taking place. The brainstem integrator, I said that it has got vomiting center, nucleus of the tractus solitarius, the respiratory center, and the cranial nucleus. They work in a coordinated fashion. They suppress respiration and facilitate swallowing if the food is good. They suppress swallowing and activate vomiting center if it is bad. And vocal cord closes. And if identified harmful, vomiting center is activated. And when these central mechanisms fail, central dysphagia or apraxia of swallowing occurs. Then central synchrony. There is an apnea during deglutition. When we are swallowing, there is no respiration. We saw the peripheral integration, there is a central integration also. So when we are swallowing, there is no respiration, so that the food does not go into the lung. That is called deglutition apnea. That is normal. Deglutition apnea prevents food escaping into the respiratory passages. It is through a centrally generated and synchronous with, but not dependent on laryngeal closure. And typically, exhalation precedes and follows swallowing, ensuring that bolus remnants in the pharynx are not actively inhaled. So before and after swallowing, there is exhalation, and there is apnea during deglutition. So posterior part of the inferior frontal gyrus contains the schema and eating behavior and social cognition. What is social cognition? We have got a disciplined way of eating. You do your prayers, Brahmarpanam, and after that you see whether everybody started eating, and then you start eating. And you don't eat from other people's plate who are sitting nearby. If they have got a food which you like, you don't take it from their plate. They are all social eating behavior. And insula is for taste recognition. And so when it is affected, you get food fats in frontotemporal dementia. They are obsessed with some kind of taste. And basal ganglia is fine tuning of the schema. Reticular formation is for alertness during eating. And cerebellum determines the rate range of various motor phenomena. So this is the motor mouth areas for so sensory and motor, and you have got the insular regions you have seen. So we have seen through the mechanisms of olfaction, mechanism of taste recognition, mechanism of swallowing from periphery to cortex, and their influence on behavior, influence on social order, identifying the enemy, identifying bad food, identifying their partners, and maternal behavior. Everything is linked with these three functions. So when there is a problem, you have to ask the question, is the problem, supposing you are very depressed, you don't eat. So that is organic or not organic. Then you ask whether it is mechanical, whether it is peripheral end organ related, or is it a cranial nerve related. And if it is cranial nerve, is it a lower motor neuron, or is it upper motor neuron, or is it a supraneuron control? Like we saw, most of them are insular cortex, medial orbitofrontal cortex, amygdala, pyriform area. So whether the problem is in these areas. So is it organic or functional, mechanical, related to the end organ, or is it in the lower motor neuron, is it in the upper motor neuron, or is it in the central connections, or is the eating problem cognitive disorder, or is it apraxia, food fat, lacking social cognition, or stimulus bound eating, neglects, and poor attention, shabby eating, which are all due to orbitofrontal connection related, social cognition related eating function. So the problems patient come with maybe premature escape of bolus from the mouth, impaired oral control, impaired opening of the upper esophageal sphincter, aspiration in the larynx, or central failure resulting in apraxias. And so, when a patient comes with a symptom of olfaction or taste or swallowing, they are linked functions, and you have to identify. We have discussed those symptoms then and there. Each one, otherwise, like everything in neurology is a huge topic. So we have made the template at every level. So finally, is the disease at the lower level, which we have seen for all the three functions? Is it at the middle level, the brainstem, or is it at the higher level? Like that, you have to ask questions and identify. So thank you. Any questions? This also I template only. My usual sessions, I only give a template. No?
Ma'am, what is chin rubbing as a protective mechanism?
Sir, when we are not liking somebody giving you a food, instead of putting in the mouth, you just do like this and say that you are hesitant.
Okay.
Social behavior, saying that you are hesitating.
Okay, ma'am.
Social
Second thing, one thing more, ma'am. Like in the olfactory surface, olfactory thing, epithelium, lot of protective mechanism is there so that toxin do not enter inside the brain.
Yes, sir. Yes, sir.
Different immunoglobulins, other protective
Yes,
mechanism. In the old days, if that mechanism is very weak,
yes, sir.
if that toxin can enter into the brain and they may produce degeneration.
Yes, sir. That is one of the hypotheses. One of the hypotheses.
And third thing, ma'am, regarding telereceptors.
Yes,
when
sir.
there is about to be tsunami or a storm, animal become very conscious.
Yes, sir.
So is that they sense some waveform?
Yes, sir. Definitely, sir. Because that is one system which is very weak in humans. Most of the systems developed in humans, whereas this system became suppressed because we developed cortical discriminative function and they did not depend on the primary olfactory senses. So that is poorly developed in humans and better developed in animals.
Ma'am, is that yogis, they are able to forecast and they are able to see so many things? Is that their tele system become more active?
Definitely, so I see, because in Bhagavad Gita it is said, Krishna will tell Arjuna, you cannot be, if you cannot believe that I am God and I am telling you to do this action, you don't have the mortal eyes to see me. Therefore, I gift you the divine eyes. Our perceptive range is very less. Whereas the yogis train their inner system to perceive beyond our perceptive capacity. We are limited by our capacity to perceive. Whereas by expanding their function, they have expanded their sensory purview, like the gifting of the divine eye to Arjuna. Then he saw the Vishwarupa of Krishna. Vishwarupa is there. We have only one dimension, clear vision. Second dimension is partial, and third dimension is constructed. So if you see a person in front of us, front is very clear, that is one dimension. Side partly we see, that is the second dimension. Back we construct, that is the third dimension. Whereas universe has got so many innumerable dimensions. That is the Vishwarupa of Krishna. Our limitation is our perceptive limitation.
We are very limited, ma'am.
Yes,
Thank
sir.
you, ma'am. Excellent class, ma'am. Thank you very much.
Thank you, sir. Thank you very much, sir.
Good day, ma'am.
Thank you, sir. Shall we, if there are any questions, I will answer, otherwise we will close. Shall we close? Are there any questions?